Hello everybody, and welcome to the third webinar in our Experts on Air series on high flow oxygen therapy. My name is Caroline Brown, and on behalf of Hamilton Medical, I'd like to thank our two experts, Dr. Oriol Roca from Spain and Professor Sharon Einav from Israel, for taking time out of their busy schedules to join us today. They're going to talk about how to monitor patients during nasal high flow. If you're joining us for the first time, please note the session is being recorded and a link to the recording will be sent out to you in an email just a few days after the event. Your cameras and microphones have been switched off by default, but we'd love you to ask your questions using the Q&A function. We hope to see lots of questions coming in throughout the session and we'll try to answer as many as possible. And now I'd like to hand over to our interviewer for today, Sharon Einav. Thank you, Sharon.
Thank you very much, Caroline. This session is going to be focused on monitoring, as mentioned, and our speaker today is Dr. Oriol Roca. Oriol Roca is a consultant in intensive care at Vall d'Hebron University Hospital in Barcelona. He's focused his research on acute respiratory failure and the adult respiratory distress syndrome. His research spans from non-respiratory support, non-invasive respiratory support systems to invasive mechanical ventilation, going all the way to ECMO. But a main part of his research is focused specifically on the use of high-flow nasal cannula in patients with acute respiratory failure. Before I turn over Oriol, why don't you say hello to everybody? Just wave. Great. Before I turn the right of speech to you, I'm going to run a quick poll that we have constructed here for the audience, and everybody can vote, as you can see. And we have two questions in this poll. The first one has to do with patient monitoring during nasal high flow oxygen therapy. As I launch this poll, what I'm showing you here is the poll. The question is, which parameters do you monitor regularly during nasal high flow oxygen therapy? Please, everybody answer. And we'll try to run this as quickly as possible. You have about 40 seconds to respond to the poll, to the multiple questions. And let's show people what your opinions are. This is a great opportunity to show everybody what you think. As you know, these sessions are shared afterwards in YouTube. And why don't we show the world what everybody's doing? Do you monitor respiratory rate? Do you monitor heart rate? Do you monitor saturation? What about PaO2, PaCO2? Who monitors that? FiO2 to PaO2, ROX index, respiratory muscle fatigue. Does anybody monitor that? So as you can see here, the numbers are increasing and we're almost done. I'm going to be ending the poll in 10 seconds. So this is your opportunity, counting down from now. 8, 7, 6, 5, 4, 3, 2, 1. And I'm ending the poll. And I will now share the results with everybody so that you can see what people are doing. These are the parameters that are being monitored regularly by our participants. As you can see, saturation is the most prominent monitored variable, followed by respiratory rate, and then heart rate and signs of respiratory muscle fatigue. Now that we've seen this, I'm going to stop sharing this and go to our second question. And our second question is going to be running in exactly 2 seconds. Here it is. Which of the following parameters do you think is the best indicator of treatment failure? Again, this is a multiple choice question. You have 30 seconds now to respond to this. Please indicate, this is a huge topic. What is the best indicator of treatment failure at the moment, in your opinion? You can answer again. A multiple choice question. We're 25 seconds into the poll. This is an opportunity to have your voice heard. And we're almost done. Running it into 3, 2, 1. Let's just get a couple more answers out there if people want to respond. And that's it. Thank you very much. I'm ending the poll, sharing the results with you here. Oh, this is interesting. Some people think respiratory rate saturation, signs of respiratory muscle fatigue. That's really interesting. And a lot less people are looking at heart rate and the ROX index. So let's just, now I'm going to stop talking and end the poll at this minute. And I'm going to turn the stage back to Oriol, if you would like to give your talk now, and then we'll be taking answers, questions and answers at the end of the talk. Thank you.
Perfect. Thank you very much, Sharon, for the introduction. Let me share my screen. Do you see the screen perfectly? Yeah, perfect. So I just want to briefly introduce the topic that we are going to talk about today, which is monitoring patients with nasal high flow. These are my disclosures. And the first question is obvious, why we need to monitor our patients. And in case of high flow, it's not only to assess the effectiveness of the treatment or the efficacy of the treatment, but also because delayed or late intubation has been historically associated with worse outcomes. It was firstly described with NIV, and the same results were reproduced later with high flow. This was with patients that were non-COVID patients, as you can see by the date of publication of the papers. But if we go to the more recent publications that include only COVID-19 patients, you will find more or less the same results. Those intubated later compared to the ones that were intubated earlier, and the threshold that you can choose depends on the study. 24 or 48 hours had a worse prognosis, a worse mortality, and less probability of survival. And when you put everything in a multivariate analysis, as you can see, only the age and the delay of intubation were the variables that were associated with a higher risk of mortality. So this raised the importance of close monitoring, and I will show you 2 chest X-ray with 2 patients with a lobar pneumonia, one in the left and another one in the right. And if you go, they practically have the same SpO2 FiO2 ratio, but if you go out of the chest X-ray and you look to the patient, they look extremely different. The patient on your left side is completely monitored with all the equipment that we have in the ICU, electrical impedance tomography, esophageal pressure, treated with nitric oxide, and all these kind of things. And on the right side, you have a patient treated with high flow that only wears a pulse oximeter and a non-invasive arterial tension. And obviously the question is the patient on the right under monitor, or we have the enough devices in order to detect as early as possible any clinical deterioration to avoid or minimize the risk of delayed intubation. So the problem of why we need to monitor patients is relatively obvious, and I think that we all agree that we need to monitor our patients in order to assess the efficacy of our treatments, but what we can use in the case of high flow patients. And there have been many variables associated with high flow failure. Some of them are respiratory variables, like the absence of the lack of oxygenation improvement, the persistence of high respiratory rate, the thoraco-abdominal asynchronous of the need of accessory muscles, and other non-respiratory variables, such as other organ failures different than the lung. But these studies were performed in a small sample size that included a highly heterogeneous population of patients, and they were not discriminant enough to identify those patients who will require to be intubated. if we try to condensate in a table all the variables that we can that we can monitor in the green squares, I try to highlight the ones that we can use in patients with high flow. You can use SpO2, FiO2. If you have an ABG, you can even measure PaO2, FiO2 ratio. You can use respiratory rate. The use of esophageal pressure outside the clinical research is extremely rare. And you can try to integrate different variables in a single index that try to have an additive or a synergistic effect in terms of detecting high flow failure compared to the variables that compose the index by separate. But the question that you have to be always try to keep in mind is why these patients fail on high flow. And this could be very simply explained by using this circle vicious of lung injury that describe the entity that we know as patient self-inflicted lung injury that was published 5 years ago with the Blue Journal. We have a lung injury that occasionates an impaired gas exchange that increase respiratory drive, and then we have an increased respiratory effort that at the same time increase again the capillary leak and the lung edema. And when we use high flow, in some patients, we can interrupt this circle at different points, but it does not happen in all patients. In fact, in all patients, those who fail on high flow and need to be intubated are the ones that we cannot interrupt the vicious circle of the lung injury, maybe because they need more pressure, but maybe because other reasons. But because of that is probably why the patients fail on high flow and need to be intubated. And one of the variables that we can measure or more easily measure at the bedside is the gas exchange. And we can discuss if PaO2 predicts better than SpO2, but it's difficult to measure esophageal pressure swing, and it's difficult to measure respiratory drive in spontaneously breathing patients treated with high flow. So maybe these gas exchange abnormalities are the ones that are more easily measured. And the other question is when we should escalate the treatment to NIV, to helmet CPAP, or to directly intubation. And I think that nobody has the answer to this question because it is the $1 million question. And obviously I also don't have it the correct answer. And I will show you 4 different very famous trials that have been published very recently: the Florally trial, the HIGH trial in JAMA, the recent recovery trial, and the HFOT trial, also published in JAMA with COVID-19 patients. They use different criteria for intubation, even a standard of care. And in the current clinical practice, most of times, the decision of intubating the patient depends on the physician that is in front of the patient. Maybe 2 different physicians may take different decisions according different things, and this is something that we cannot control. So probably this establish the time zero, this establishment of the time zero when the patient really needs to be intubated is the first discussion that we need to have in order to arrive to an agreement on when we have to escalate the treatment, and probably is almost impossible to achieve. In any case, I think that we have enough data to think that at least in some patients, delayed or late intubation is associated with worse outcomes when they are treated with high flow or any kind of non-invasive respiratory support. And because of that, these patients need to be closely monitored to detect as early as possible any clinical deterioration in order to minimize the risk of late intubation and worse outcomes. Thank you very much, and I'm very happy to take all the questions that you may have.
Great, thank you, Oriol. That was really well organized. We already have several questions. Everybody, in case you were wondering, please post your questions on the Q&A at the bottom of the screen. You can see it and you can write your questions up there, and I can see that we have them flowing already. So I'm going to start with a couple of questions that we already have from before. Do you think that monitoring PO2 improves prediction of high flow nasal oxygen failure?
We try to do this analysis in the Roca scores, trying to substitute the value of the SpO2 by the PaO2 in the formula of Rocs, and we had the same capacity of detecting high flow failure. So I would say that if you keep the SpO2 between 92 and 97, that clearly it's more clearly correlated with PaO2, you are in the safe zone, and then you can easily predict the same result by using SpO2. You don't need to have a PaO2 in case that you keep the saturation between the range, because the correlation between these two values is sufficiently correct to predict the outcome.
Okay, great. That's really informative, because that's the sort of thing that doesn't get published usually.
Yeah.
The next question, well, actually, it's a bunch of questions, relates to the first 30 minutes. So we have several questions relating to perhaps what do you monitor in the first 30 minutes? What do you think is important? And perhaps also, and maybe what's most sensitive, and well, what can we actually learn during the first 30 minutes in terms of monitoring?
I think that the first 30 minutes or the first minutes of the technique should be fully dedicated to explain to the patient what he or she is going to feel when we start high flow, because our aim would be that the patient tolerates the technique. And maybe it means that we may use lower temperatures that we want to use at the end of the technique, or lower flows, just to with the aim that the patient gets used to the technique. Because once the patient gets used to the technique, you will be able to increase the temperature and increase the flow up to 60, and the comfort will be, or the technique will be much better tolerated. And if the technique is better tolerated, it means that the patient will be on high flow 24 hours per day, which is the main difference between probably NIV or CPAP compared to high flow, that you can keep the technique during the 24 hours per day, the 7 days per week, if the patient is stable. And these 31st minutes, I would say that I would focus on the tolerance and then push as much as I can to the limit of the technique once the patient has been adapted to the feeling of receiving a high flow, a continuous high flow through his or her nose.
So what you're basically saying is the first 30 minutes, we should sort of hang around the patients and see how they're doing. Is that, do I understand that correctly? Okay.
Yeah, I think that starting high flow is not just, okay, I turn it on and go away. You need to look to the patient and assess the response that he or she has to different flow rates, and decide the optimal flow according to the tolerance and according to the oxygenation improvement or the decrease of respiratory rate. But the tolerance is something that the first impression for the patient is very important, because they will conditionate what will go happen later, and convince him that is, or her, that is a technique that is beneficial for his disease or her disease. It's quite important. Of course, if the patient has a more severe respiratory failure with more air hunger, I would say, rapidly will tolerate a higher flow. But in a mild, moderate respiratory failure, you will try, maybe you have some to titrate the flow is a little bit more tricky, because maybe 40 is enough and you don't need 60.
Okay, so we'll talk about the flow in a few minutes. Before we do that, I just like to ask, so, you know, you're very much a proponent of the ROX index, obviously. Can we use the ROX index during non-invasive ventilation or CPAP? And does it have similar value in COVID patients and non-COVID patients? I think those are two important questions.
About the first part of the question, which is its use in NIV and CPAP, I think it has not been validated, and it's not, I would say that I not recommend to use the ROX in order to decide anything, even in high flow patients, because at the end, the clinical judgment of that you have in front of the patient must prevail over everything. Not a number will make you decide to intubate or not intubate the patient. It's the whole picture of the patient and the trend of the patient, where he or she is going, is he improving or not with high flow? And this contemplates the ROX, but not only the ROX. The idea of the ROX comes from the Martin-Tobin rapid shallow breathing index that tries to integrate different physiological values in a single index that increase the capacity of prediction of the outcome, which is, in our case, is the need for intubation. But I will not base the decision only in the ROX, because the data that we have is purely observational. So I agree with the poll that not all patients, not all people say that the best predictor of failure is the ROX index. This is one side, and the other side is about COVID-19 patients. At the beginning, we were a little bit afraid that the question of happy hypoxemia with lower respiratory rates may change the threshold, that the threshold of the ROX index that we previously described. But very rapidly, some papers appear, and the thresholds between those that identify those patients who succeed on high flow compared to those who fail were quite similar to the ones that we described before with non-COVID patients. So I would say that around 5, if you are above 5, you are I would be comfortable having the patient in the intermediate care unit, maybe not in the ICU, because it's not necessary. And the other question is beyond 5. Beyond 5 is below 5. Sorry, it's a little bit more difficult to decide. But the thresholds to define the success were quite similar in COVID and non-COVID patients.
Right. Okay, that's important information. Now, what do you think is the best indicator or the earliest indicator that the flow is selected properly? You started to mention flow settings, how you decide. Do you have a way of making the decision? Like, what can we tell the clinicians out there in terms of how would you do this?
The more severe the patient is, the higher flow I try to use. Because at least in hypoxemic respiratory failure, because we know that the higher the flow, the higher the effect or benefit, I would say, in terms of hypoxemic respiratory failure. I think in the last webinar, Tommaso showed that in terms of dead space and minimum ventilation, you achieve the plateau at 40 liters per minute. So I would say that in hypercamic or COPD patient, maybe 40 is more than enough for the treatment of hypercapnia, I would say. But if the patient tolerates, I would try to use the highest. What we are trying to assess now or to investigate is how we could individualize the flow. And individualize the flow based on physiological variables that could be correlated with clinical variables that could be easily measured at the bedside, that then could provide a more useful answer to these questions. That now it's based mainly on comfort and as high as you can. but nothing more than that we can say now. What is true is that, and we have learned this from the studies made in post-extubation period, is that the lower, the patients with lower risk of reintubation need or tolerates lower flows compared to the ones to high-risk patients that really tolerates higher flows. So it seems logical that the more severe you are, the more flow you need, because the more dyspnea you have. So the more support you will tolerate. And everything is completely linked. But I would really like to have a physiological background using EIT or esophageal pressure that really could correlate with a clinical variable that you can easily measure everywhere at the bedside, then say, okay, I'm in the good direction, I should use 40, 60 is too much in this patient. And sometimes the patient have the reason. And the good thing with high flow is that you can ask to the patient. And if the patient says no more than that, then it makes no sense to try more, at least at that moment. Another thing is that the patient change 1 minute after or 2 hours later could be the same patient could be in a completely different situation, and then you have to titrate the flow and vary the flow according to the patient condition, which is another thing.
So, you know, since this session is about monitoring, how we've decided that we have to be at the bedside at the first half hour, how often would you, like, if we're using the high flow nasal device in less monitored environment, how often would you recommend that the clinician actually go in, look, take another look at the patient, and, you know, decide on how to adapt? How often would you do that? How do you do that?
Outside the ICU setting, you mean? Or in the
care.
ICU? Intermediate care.
ICU is easy. Intermediate care.
Intermediate care. In our hospital, there is always a doctor there, even in the intermediate care unit. So it's as easy as in the ICU, I would say. But we try to keep at least during the first 24 hours in the ICU when the patient is admitted in the hospital, if the FiO2 that he needs is over 0.5, let's say, because you don't know how the patient will respond to the treatment, at least in the first 24 hours. If you can stabilize the patient and you need, let's say, an FiO2 around 0.5 and respiratory rate is below 30, and the patient tells you that he is or she is comfortable, maybe you can discharge to the intermediate care unit. Outside the ICU, which is something that we did in COVID, during COVID, because we had no other option, is something that at least in acute hypoxemic respiratory failure, I always try not to do, at least during the first 48 hours, because you never know what will happen. And sometimes in the ward, depending on how the hospital is structured, it's too risky. At least is my opinion. If the first 24 hours or 48 hours have been covered and there is no complication and the patient is FiO2 of 0.4 or 5 with 40 liters per minute, maybe the patient can be discharged even to the ward, depending on the extension of the check X-ray affectation or the of things. But at the beginning, we tried to give to admit to the ICU at least the first 24 hours, and if the patient is stabilized, then decide when it could be discharged.
So high level monitoring in the first day or two, and then perhaps it's possible if the patient has shown that they're stable, then after that time, you continue the high flow nasal oxygen, but in a less monitored session area, perhaps. Okay, yeah. So to our next question, We have a question asking about whether you think that there is a way to decide on weaning based on monitoring.
I think there's no literature about that, but I think that we have to apply the common sense and make the parallelism with mechanical ventilation and pressure support and PEEP. I would say that you have to decrease first with the highest tolerated flow, the FiO2. And once you have an FiO2 below 0.5, then you can start decreasing the flow. And if the respiratory distress reappears when you are decreasing the flow, I would increase again the flow to the previous step and targeting always the FiO2 that we need according to the SpO2 that I have decided is the best range for the patient that I have.
Okay,
So,
and yeah, go on, sorry.
No, sorry, no, just to summarize. So highest flow, targeting FiO2 according SpO2, and then when I have an FiO2 around or below 0.5, then starting decreasing the flow.
And then at one point, is there a specific point where you decide that you also, based on your monitoring, that you can actually maybe do a reverse ROX index to decide to take the patient off the high flow nasal oxygen?
In fact, it has been done by the group of Jean-Pierre Frat and Arnaud T. Try to define a threshold of the ROX that predicts the win, the successful weaning of high flow. And I would say that I would make things easy. If you have 30 liters below 0.4 of FiO2, you can perfectly try an SVT of conventional oxygen and directly switch to conventional oxygen and see what happens. And if the SVT means switch to conventional oxygen, it's a parallelism for mechanical ventilation, but you can switch to conventional oxygen, and if the patient keeps with the respiratory rate stable and SpO2 stable, it means that the patient does not need high flow anymore.
Okay, great. That's really informative. Now, a lot of practical tools, I think, in this session. I think this will have to be the last question because we're almost at the end of the presentation. There have been a couple of questions on patients with tracheostomies, and people have been asking whether you can use the ROX index on a patient with tracheostomy, on what basis perhaps can you reduce the flow, or and so on. And, you know, we have this new thing that you can put the high flow nasal oxygen on the trachea. So what can you tell us about that?
One thing that people have to remind when using ROX is that the studies that we did with ROX were at the beginning of the treatment with high flow. So it means that where the ROX was calculated with the maximum tolerated flow, which is a medium flow of 50 liters per minute. And the flow that you are giving to the patient also has an impact in oxygenation, and therefore also has an impact on the ROX value that you get. And this was shown also in a post-hoc analysis that we did with Tommaso, that we compare the ROX index with 30 liters and 60 liters. And 70% of the patients increased the ROX and increased the expiratory lung volume, and 30% of the patients did not increase the ROX, which means that maybe 30 liters was more than enough for these patients. So when you have a patient with tracheostomy, you are in a completely different situation. Probably these patients are on high flow, but not 60, maybe 30 and 40, with a very low FiO2, and they have the benefits of heated humidification, which is something that improves secretion clearance, which is a thing that is very important for the successful weaning in these patients. So I would say that there is no direct translation of the values that we have of the ROX to be applied to the tracheostomized patients. So I will not use it even until we have no more data about that. There are some other techniques that are useful to predict the cannulation that we published with Gonzalo Hernandez in New England, like the number of times that you need to aspirate the patient in the last 24 hours. And one thing very easy to measure, which is like that, you can predict very, very easily if you can decannulate the patient and go to conventional oxygen therapy. So I would go more for this way rather than to using the rocks for the reason that I told.
Okay, great. So we've covered all the way from when to intubate to all the way to when to decannulate during the session. And we're going to have to wrap up because we're out of time. Thank you very much. This has been wonderful and very educational. I'll be wrapping this up, and thank you everybody for attending.
Thank you.
So a big thank you to our two experts and of course to all of you for taking part today. We hope you enjoyed it and you found the information valuable. Watch out for our email in the next few days with a link to the recording, as well as a link to answers for any unanswered questions, because I think we have a few that maybe we didn't have time to cover today. And if you haven't already signed up for future events in this series, please just follow the link that's been placed in the chat and sign up now. Goodbye from all of us at Hamilton Medical. Thank you very much for attending, and we look forward to seeing you again soon. Bye-bye.